Airedale NHS Foundation Trust has got a long history of using telemedicine or teleconsultation to help people in a variety of clinical settings. We started our work in this area about 6 years ago, working with the prison service, delivering specialist health input into teams working in the healthcare suites in a number of English prisons. Today we're currently working with 20 prisons, geographically located from the Scottish border down to the Dorset coast. And we found this to be a very successful way of reaching people for whom healthcare is something that's actually quite difficult to access. We subsequently moved on through a partnership with Red Embedded Design and the ALIP programme run by the Technology Strategy Board to build telemedicine systems that could be used in a person's own home. These are based around set-top box technology and use the home television as the display device. To date, we have a number of these units deployed in the homes of people with chronic diseases such as chronic pulmonary disease, heart failure, palliative care needs and diabetes. We're extending this into a range of other contexts, including nursing and residential homes. When a patient calls in, or indeed when we call a patient in a proactive way, the call is initially managed by an experienced nurse, typically somebody with coronary care and high dependency expertise, who's able to form an assessment of the needs that patient may have and how best to resolve those. If the need arises, the call can be escalated to a consultant physician, and during the day those are resident in our 24-hour telemedicine facility. Out of hours, the on-call team will pick up this triaged call. I'm speaking to you now from Airedale Hospital's Telehealth Hub. This is a 24-hour clinically staffed facility which allows us to consult with patients either in their own home, residential, nursing homes, hospice or even GP surgeries. When a call comes in from one of those locations, it's initially triaged by an experienced member of our nursing team. Now, these are typically people with coronary care and high dependency expertise, and they're more than capable of taking the history and forming an initial view as to the needs of that individual. When necessary, the call can be escalated to a consultant physician, and in normal working hours, those physicians are resident in the hub, so there's an almost immediate access to consultant level expertise. In the out of hours period of the day and night, the calls are escalated to the on-call team, be that specialist registrar or consultant who may be at home. Our evidence over the first quarter of 2012 shows that of those calls we receive, 52% are leading to the avoidance of a need for hospital admission. Previously, all of those patients would have had to be admitted acutely. In a small proportion of cases, the GP no longer has to visit the patient's home, and in about 13% of cases, the patient does require admission because of the severity of their illness. However, where admission is necessary, we're able to streamline that process so the person no longer has to travel through the A&E department with attendant waits. They can go straight to the admissions area, and the medical staff in that area will have been primed, they will know what's coming, and they can prioritise their work accordingly. We use System 1 as our electronic record system, and because the vast majority of GPs in the area use this particular system, we're able to communicate back to the primary care teams in real time, so everybody is continuously aware of what's happening to their patients. Our patients' level of satisfaction with the service we deliver through the hub is extremely high, and we now are developing a whole series of use cases which show the benefits of this particular approach to people in a whole range of clinical contexts. In the course of our work with teleconsultation, we've realised that you need a range of options to handle these calls. For a person in their own home, a set-top box-based solution which links to their television is really appropriate. For a busy clinician working in their office, they really need to use their PC, and so the system can also run to them through that computer on their desk. For the hub here at Airedale, we need to handle calls, we need to be able to deal with multiple calls, to queue calls, to transfer calls from person to person. And so a highly sophisticated triage panel which deals with video calls in this way has been developed and is in use 24 hours a day here. And finally, for those clinicians who are on the move, a mobile tablet PC based version is available so that, for example, when somebody goes into a patient's home and wants a second opinion, they can access that without a need for dedicated software. They can just take the video conferencing to the person rather than bring the person to the clinician. In all of these ways, we aim to deliver an immediacy of response from the clinical decision makers, and in so doing improve the quality and the experience that the patients experience, and also reduce the cost to the overall healthcare system.